Welcome, everyone. My name is Dr. George Margelis. I am the independent chair of the Aged Care Industry Information Technology Council, and it is my great pleasure to welcome you today to what is a very important webinar on a very important topic facing us going forward in the use of technology in the aged care sector. So the topic for today, data standardization and assessment systems for aged care. We'll be covering a fairly broad area around the use of standards, and in particular their use in the roles of assessments. First of all, I'd like to start off by acknowledging the traditional owners of the lands upon which we meet. I'm based in Sydney, so I pay my respects to the Gadigal people of the Eora Nation, but as we are spread all around the country and potentially all around the world, I'd like us all to pay respects to our traditional owners of the lands upon which we meet, and pay our respects to the elders past, present and emerging, and to any traditional owners or Indigenous folk joining us today. We welcome you on board. A little bit of housekeeping before we kick off. I'm assuming by now most of us are quite versed in the use of Zoom over the last couple of years, even after the pandemic. But a couple of things to keep in note. All your microphones have been muted because this is a presentation webinar. If you do have any questions during the event, please feel free to click on the Q&A button at the bottom of your screen and enter your question there. We will be managing the questions and asking them at the end of the session. This session is being recorded, so if you would like to share this with any of your colleagues in the future, please feel free, and that you will be made available in the next few days after we tweak it a little bit and make sure it's ready for distribution. So the question raises around data standardization. Why are we here? So the council has actively supported the use of evidence to drive technology decisions in aged care since its inception in the early 2000s. We saw in the Royal Commission that highlighted the need for a standards-based clinical information system in aged care. However, it did not discuss in any detail the issues around those standards. Therefore, the council saw data standardization as an essential project to enable aged care providers to make informed decisions around selection and use of such clinical systems. As a result, we entered into a formal partnership with the University of Queensland Centre for Health Services Research to explore this and a range of other issues in the use of digital technology in aged care. So, like I said, we've been discussing this topic for quite a while within the sector, and our research points to a number of priority areas to consider around data standardization. We believe it is critical for all aspects of clinical systems and other data systems in aged care. And we've had the opportunity to learn from the other healthcare sectors as they've gone through their digitalization journey. There are many issues that relate to standardization, and we could spend many days discussing just those issues. However, just a quick summary, issues like interoperability between systems, so linking in across the entire health and social care sector so that we actually have a single view of individuals as they go through the system. The need for common data sets so that we can compare like with like, and we saw in issues like the serious incident reporting and the star rating how important it is to have a common data set with standardized nomenclatures and standardized terminologies and standardized concepts of what we're looking at. We look at medication safety, and this has been raised a number of times in the acute care sector. Lack of standards in that space alone can lead to significantly adverse effects. So we need to make sure we've got this on board early. And finally, the transfer of information. And we've seen the recent discussion by the Australian Digital Health Agency around the transfer summary document. The need to be able to do secure messaging in a standardized way so that irrespective of who in the system is receiving information, we can ensure that the right information gets to the right person at the right time. These topics and many more are significantly affected by standards. So going forward over the next few months, we intend to have more webinars looking at the various issues. But today we are focusing predominantly on the assessment side of things, which is a critical part of the entry into the aged care system and the continuing evolution of care within that system. So when we look at this, we talk about a number of very important industry considerations. So yes, we are at that interesting point in our evolution where we're shifting from paper-based records and suboptimal digital systems to standards-based high-quality digital systems. It was a requirement of the Royal Commission. It's a requirement for us to be able to deliver the high quality, safe and effective care that's required by older Australians going forward. And just today, we're seeing the release of the Productivity Commission report, which tells us that the demand issue is about to significantly increase. So therefore, how we manage that, the delivery of those services is critical. The need for interoperable open standards-based platforms is critical because aged care is not a silo. It is part of an interconnected, interoperable care system, which spans acute care, primary care, social services, community services, and many other factors that we need to link into. So interoperability is key. That requires us to have the build on open standards. Focusing also on the need for consistent and accurate terminology. We need to make sure that what we're saying is transferable between providers, between carers, and between consumers, so that in such a way that we don't drop the ball in any of those areas, and which leads to some of those poor outcomes we've seen in the past. We do know that the government is currently developing a digital aged care strategy, and we were working closely with them to align ourselves with that strategy. But again, to do that, both of us need to be talking along common standards. So we're working well with the department to ensure that the concept of standards is ingrained in the new digital aged care strategy, and those standards are those standards that are usable and effective in the community. As part of that alignment with the government strategy, we work with the Australian Digital Health Agency around integrations with the My Health record system and its associated services, and we will see more announcements from the Digital Health Agency in the future. They've just released their national digital health strategy, and aged care plays a significant role in that. One challenge we all face, and we will continue to face going forward, is workforce. So how do we develop systems that are usable by the existing workforce? What are the changes we need to develop in our workforce to make better use of these systems? How do we evolve our systems and our workforce in parallel to provide the better outcomes that we're looking for? Very importantly, we need to engage with the vendors who design and implement these systems, because at the end of the day, whilst we can develop standards, it's the implementation of those standards in clinical information systems designed by a number of vendors, both local and international, which is critical for their use in our provider sector. So we need to work very closely with the vendor community to ensure that the standards are feasible, usable, and implementable. And those are the three issues that we need to work on. And I do highlight that we are running a vendor forum later in September to discuss the specific issues with the vendor community. And finally, but very importantly, we need to be able to demonstrate the value of the required investment to implement these systems in our sector. So it's all quite theoretical when we look at what the technology can do. Implementing technology requires aged care providers to significantly invest in that technology, and having been involved in a number of boards over the years, that requires a business case and an investment case. So we need to examine the use of these technologies and highlight where they add value to aged care providers in the delivery of care, and how we can help providers get that value out of those systems. And again, that's one of those ongoing challenges we face, which links in with workforce. How does the workforce utilize these very powerful digital information systems to deliver higher quality, better care? And those key issues, I think, will something we'll be discussing over the next few months. We look forward to ongoing discussion. I do highlight that the council does have a LinkedIn group where we foster discussion. These are key issues we need to look going forward. But now I'd like to hand over to Dr. Ronald Dendere from the Health Informatics Research Fellow at the University of Queensland Centre for Health Services Research, who's been commissioned by the council and has done some amazing work looking at the use of standards in assessment systems. Over to you, Ronald.
Thank you, George. And I also want to, at this point, to thank the Aged Care Industry IT Council for commissioning the work that I'm presenting today, as well as extending their invitation for me to come and present the work to a national audience. I really appreciate it. I also want to start by acknowledging my colleagues who are here on the call, especially Dr. Mary Hargrave, who's been kind enough to share my slides on my behalf. So the work that I'm presenting today really is a product of teamwork, and I'm really happy and privileged to be working with these wonderful individuals. So I would like to begin today by looking at the context in which this work was done. So these are really not so much the reasons why we undertook this study, but more of an acknowledge of the external environment in which we were doing the study. So firstly, Australia does not have a broad use of common or standardized CGA systems in aged care. And this is really not an indictment on the government or this industry, but more of a nudge for us to go towards that direction. For the past year, or a little bit more than that, I think it's close to 2 years now, the Institute for Health and Welfare has been developing an MDS. While it's been a while since we had updates from that work, we are looking forward to hearing how that's progressing at next month's webinar. And I'm also glad that George mentioned that the government is currently developing a data strategy for aged care. That is also one of those external factors under which we conducted the study. And we also just happen to know some CGA systems that are available on the global market. So we felt that we might be able to at least contribute to all these factors and bring some light into how we can harness what's already out there and at least make the work a little bit easier. So George is asking me to define some of these acronyms that you see. So the CGA really stands for Comprehensive Geriatric Assessment System, Geriatric Assessments. We see plenty of benefits in using these systems across the residential and acute and community care. So our objectives for this study were really to identify structured comprehensive geriatric assessment systems for residential and community aged care. And once we identified those systems, we also wanted to do an evaluation of those systems based on a predetermined list of criteria items, and then finally go on to produce a report of our activities and results. So in conducting our work, we noticed that there isn't a commonly adopted definition of what a comprehensive geriatric assessment system is, and definitions do vary in the literature and industry, and more often than not, we also see the term used synonymously with geriatric assessment. But for this study, it was really important to begin with a precise definition, and the most common definition that we see in the literature, which we happen to agree with, describes a multidimensional process that evaluates or examines more than one aspect of health for the individual. The process usually involves healthcare professionals from more than one discipline that involves in one way or another in the care of the individual. And the whole goal for the process really is to identify medical, social, and functional needs of the consumer, culminating in the development or update of an already existing coordinated care plan. Like I said before, we do see plenty of benefits of CGA, and those are largely dependent on the setting. We do see that these benefits are dependent on the setting, but what we see is that across the residential, acute, and community care, the common benefits are that the CGA is associated with lower risk of falls and mortality. And beyond those baseline benefits, if you may, we also see additional benefits in the residential care of improved cognitive and physical function. And if you look at acute care, we also see additional benefits that include reduced length of stay, lower risks for delirium and pressure injuries, as well as declining mobility, and also a higher chance of discharge to home. And for the community care, in addition to all those benefits across these sectors, there is the additional benefit of a reduced risk for frailty. What we needed to do was to define what exactly is an assessment system. And we see this in the same way we see variations in the definition for comprehensive geriatric assessment. We also see variations in definitions of what exactly is a system for conducting CGA. But for the purposes of this study, we see a system for CGA as a framework for conducting assessments that is a collection of definitions for data items that should be collected and how those data items are collected, as well as how observations are recorded and scored. We also see that it's important that a system should have possible derivative applications to support decision-making for clinicians, although that really is not a necessity, but it's a really nice must-have. So that's how we defined a CGA system for this study. So really, there are two approaches to CGA systems. The first one, which we loosely define as a build-your-own approach, consists of a collection of standalone assessment tools. So this, for example, this could be a collection of the Bethel Index for activities of daily living, Braden scale for pressure injuries, all brought together as a unit in order to conduct what is a comprehensive assessment rather than assessing different or standalone aspects of health for the individual. And then on top of that, we had the people usually have bespoke items to cover gaps that are not covered by those standalone items. And then on the other hand, we have off-the-shelf systems that are available already pre-built and ready for deployment. And those really are available for free in some cases, or for purchase, or under license for use. So looking at the build your own approach, whilst it gives control of the content to the provider or the implementer, there are some certain disadvantages to this approach. First and foremost, the standalone tools that are utilized are usually developed in isolation, and we often see duplication in data items across those different assessment tools. And secondly, when it comes to those made up bespoke items, we are not really confident that they are evaluated for psychometric properties. That is to ensure that they are measuring what they are supposed to be measuring, and also that there is reliability in the measurements across time and across individuals. And more often also, it makes it difficult for software suppliers to build decision support applications on top of those bespoke items, as well as more associated costs when it comes to training those who are supposed to conduct those assessments, because they would have to be trained in the use of multiple tools, and they would need to adjust to the different configurations of those duplicated data items across the different tools. On the other hand, for the off-the-shelf assessment systems, while there is the disadvantage of having no control over the content, because a lot of these systems are provided to the implementers on the condition that they have to implement the systems as they are without any changes. There are some advantages of going with that, going with this approach. First and foremost, the data items are designed to function as a unified software package, and the content is updated by experts as our medical knowledge evolves. So it really takes away the burden of keeping up with that medical knowledge and updating the systems, as well as the testing, which can be expensive away from the implementers to the developers of the systems. And again, we see that training approaches for those who will be conducting the assessments is simplified simply because those data items are configured to function as a unit, and there's less redundancy and duplication across the system. So with that, our method really was to conduct a collaborative development of the evaluation criteria first and foremost. And we did this in collaboration with the industry user group, which I think some of them will be on the call. So what we did was we looked in the literature, identified which items considered important or critical in any geriatric assessment system. We then compiled a list of those items and presented them to our industry user group for ratification and also for identification for any further items that we would have missed. We then designed and went on to conduct a two-stage systematic search of the academic literature, as well as grey literature, which included an extensive search of the internet web resources. The first stage of that stage was to identify CGA systems. And in the second stage, we sought to gather evidence in order to evaluate the systems based on those criteria items. We then proceeded to evaluate the systems and then drafted a report, which George earlier alluded to for release sometime, possibly next week, I think, or the week after. So what we have here is the list of criteria items that we produced in collaboration with our partners in the industry. And now, in the interest of time, I will not go into detail on what each one of these are, but I'll just highlight a few of them. So firstly, each system we sought to evaluate if each system is suitable for each setting that it was designed for. And we also wanted to make sure that if a system was ever to be considered for implementation in the Australian context, it had to be available in the English language and preferably in Australian English language. And perhaps more importantly, the items on the assessments should have proven reliability. So that is that they can be reliably scored between individuals as well as across time, and that they were valid in the sense that they were measuring what they were supposed to measure. We also looked at coverage, which basically looks at how comprehensive the system is. We also looked at if there is information available for information and material for training those who conduct assessments, and also that there is support for implementing such a system, as well as ongoing development to update those systems with evolving medical knowledge. So what were the results of our activities? In the first search, we really identified about 1,700 records across 8 databases, which we screened down to 295 records across those different stages. And we also identified a further 630 records. We also identified 335 records from the internet search. And so altogether, we reviewed 630 records for looking for descriptions and details of assessment systems. And what we have here are the 15 systems that we identified. So we found 7 systems that are designed for community care and 6 systems for residential care, as well as 2 systems that are designed for multiple settings that included both residential and community care. Now, in identifying these systems, we treated country-specific versions as variations of an original system, and we only went on to report only on the original system. Now, I must apologize, there's so many acronyms on this slide. So really the purpose, I don't expect you to read through all these, but the purpose of this slide was to give you a sense of what those acronyms stand for. And in any case, if there is any chance of distributing slides after the presentation, you can at least have a reference to what those acronyms stand for. So here we have a little bit more detail of the systems that we identified. So most of the systems we identified have their origins only in a handful of countries. So that is the US, Australia, UK, and Canada. And the CARE system, which is highlighted here, was the oldest system we found. It was published in 1974, which is more than almost 40 years, 50 years actually ago now. And on the other hand, the CHAMP was the newest system, published only towards the end of 2022. And finally, the INTERI LTCF, or the long-term care facilities, and the minimum dataset 3.0, where they have the latest versions of their respective systems, published in the first half of this year. And so, after having identified these systems, the second stage of the search was really targeted towards uncovering the evidence for those systems in order to help us evaluate those systems against those criteria items that I described before. Here we did another search, and we identified across the same databases, we identified well over 3,000 records, which we screened down to 73. And reviewing those reference lists, we identified another 20 articles, bringing the total number of the records that we reviewed for this stage to 86. Looking at the evaluations, I really must apologize for a very busy slide, but the idea here is to provide the audience with a visual of the performance of each system against all those criteria. So what you have here on in the first column is a list of those systems that we identified. And then what we have in the first row is the criteria items against which those systems were evaluated. And the color coding scheme really is, it shows a progression from no color through red, orange, yellow, and green, indicating a progression from the lowest performance to the highest performance. Oh, before we do that, really what we wanted to do here is to highlight what you need to really look for here in this slide is across, for each system going across, you want to see a lot of green, which indicates high performance against each of those criteria items. Some of those items have a score of 1 or 0, which indicates only bad performance or lack of evidence, as well as good performance or presence of evidence for us to evaluate those, the system in that criteria. The interesting ones were the data, that is the reliability and validity, as well as the coverage. So the only exceptions are really the reliability, validity, as well as the comprehensiveness of the coverage, which even though are on the same color codes, represent a spectrum of those performances. So what we have here, we compiled an aggregate score by simply summing up the individual scores of those individual criteria. And with this very rudimentary scoring approach, it helped us really to summarize the performance of each system using a single figure. And I must state that we did not attempt to weight any of the individual criterion in calculating this aggregate score. So really, it's just a summation of those individual scores. And based on the criteria that we have, the maximum overall score that any system could attain was 26. And again, here we have the same color coding scheme to present a visual summary of the score of the aggregate scores. So here we see that the inter-eye home care and inter-eye long-term care facilities instruments, which both originate from the resident assessment instrument, had the highest score. And in the testament of the strength of the systems originating from the resident assessment instrument, the MDS 3.0 had the second highest score, failing to meet a perfect score purely on the basis of its concentrated use in the US. The Easy Care was the only system with an aggregate score of 20 or higher. So you will see that it's in the second bracket from the highest score here, highlighted in yellow. So if we come back to the whole table and again, just take a closer look at those numbers, then we begin to see the margin of the lead inter-eye systems have over the competition, which based on our rudimentary scoring items is not quite reflected in those scores. So if we start by looking at the psychometric evaluations, the two inter-eye systems and their cousin, the MDS 3.0, both have strong evidence to support their reliability and validity in a multidimensional tests. So both systems were tested extensively across different dimensions. So that is reliability and validity was tested for most items on the instruments, as well as testing for domain performance and outputs of those applications that are built on top of the instruments. And they all exhibited adequate to excellent performance against those tests in those tests. And we only saw a comparable evaluation to the performance of these high-performing inter-eye systems only in the care system. However, the inter-eye systems still hold an edge by virtue of being tested and maintaining high performance in more countries and very diverse jurisdictions. So it indicates their generalizability across different populations, something that we did not see in the care system. And again, if we look at decision support, what we have in the table on your left here, we scored a point for each system that had one or more applications built on top of the data collected. However, we found a wide range of types and the number of those applications across these systems. But one thing that is evident is that the inter-eye systems have the most extensive decision support tools. And these decision support systems really cover clinical assessment protocols, outcome scales, resource allocations, and risk screeners for common geriatric syndromes. And they even have quality indicators built on top of the instruments. And in another testament of the performance of the inter-eye systems, as well as the MDS 3.0, these are the only systems that we found that have representations in a terminology system. And even though they may only have representation in a single chord set, which is the LOINC that you see here, we see this as a testament of the support and acceptance of the systems across the wider healthcare community, purely because the extensive negotiations that go into representation in an international court system like this is really dependent on perceived use of the systems or healthcare items. So we see that as an indicator of the acceptance of the systems and wider acceptability for the inter-eye systems. Finally, the inter-eye organization has an edge over its competitors in the sense that it is really, really easy to find information about the systems. Their websites, I must say, it's actually more than just the one. They do have a central website as well as country-specific websites, all of which are very informative and have up-to-date contact information. And in the process of conducting this review, we really found it easy to find information and navigate through their sites. In comparison, we did not find any functioning website for the EasyCare, which is the only other non-inter-eye system with an aggregate score of 20 or more. And in addition to the information that is available, the Inter-Eye organization also has long established processes and materials for supporting implementers, as well as training and certification programs for assessors, all of which the information for these is available on their websites. And just so that I don't talk only about Inter-Eye, I mean, it was the best performing systems, but also we did find some really good systems. And the second best performing system was the EasyCare. But although it performs really well on most criteria, and it appears to be very, very popular in many parts of Europe, evidence for its psychometric evaluations and performance is much, much weaker than Inter-Eye systems, and also weaker than most other systems. We also found contemporary information on the implementation of EasyCare really scarce, or at least publicly facing information was really scarce. And we think this probably makes it harder to make any informed decision for any potential implementers. And we see that as a really prominent weakness. And coming back to the main table, we do have some systems following closely behind the EasyCare. And here we see the CANE, the CARE, and the OM FAQ are the closest systems that come to the EasyCare. And just looking firstly at the CANE, this was really one of the most popular systems in the review, with translations from English into at least 16 languages and adoption across Europe as well as the Americas. It is designed for use in multiple settings, including community, acute, and residential aged care. It performs really well on most criteria, but we couldn't find evidence of organizational support or software support for those intending to implement the system. It also doesn't have, or at least doesn't appear to have, any applications built on top of the data collections tool, which limits its decision support utility. Next, we have the CARE, which has really great psychometric evidence and has several companion applications built for decision support, including risk screeners for dementia, depression, ADL impairment, as well as others. However, its performance on data burden is poor, and we found out that it actually needs an average of about 90 minutes to complete a full-length assessment. And also with no available information to indicate any updates to the system since its publication in 1974. The CARE also performs poorly on important criteria for successful implementation. We also have the OM FAQ, which has above average psychometric properties and performs really well on most criteria. But the absence of evidence of ongoing development, software support, its prominent weakness. In conclusion, our study has revealed that there are some really robust systems available, ready for deployment out there. And while there is wide variation in the characteristics of the systems, we found that the Easy Care, the Inter-Eye Home Care, the Inter-Eye LTCF, and the MDS 3.0 are the strongest systems. Of those strongest systems, the Inter-Eye Home Care and Inter-Eye LTCF are the best performing systems according to our evaluation criteria, which with strong performances on the basis of psychometric evaluations and evidence, extensive and thoroughly validated suite of applications for decision support, the presence and the use of data that is configured for multiple use cases, uptake in several and very diverse countries, as well as readily available information and material for implementing, for supporting those who intend to implement these systems. And I think, yeah, that's all. Thank you all for taking time to listen to the talk.
Thank you, Ronald. That's a very comprehensive report. And as you said, the final report should be available in the near future. We've got a couple of questions starting to pop through. And this one's probably goes to yourself. And I think we're inviting Len to join out as well for questions and answers. So the first question is, how is a comprehensive geriatric assessment system different from the standard care management system? Ronald or Len, would you like to comment on that?
I think, correct me if I'm wrong, I think what this question means is that what is the difference between the software that is used to conduct geriatric assessments and an assessment system is. So what we see an assessment system is that it's the data set that sits within a software that is used by the user. So it's really the data sets, the data that is collected, the process that happened behind what you see on the screen as one is conducting those assessments. That is what we define as a system. So it's really different from the IT or the software that is used to sort of bring the assessment system to life and allow the interface between the user and the underlying data set and applications.
Okay, so in that respect, would the CGA be integrated into their care management system as part of their assessment process? Is that the goal?
It's quite possible, yes.
Yeah. Cool. I might actually ask Len, so from a geriatrician's perspective, how important is those initial assessments and the ongoing assessments and the standardization of that assessment process throughout the clinical journey of an individual seeking care? Any comments on that, Len?
Very important. I'll just to go back to that previous discussion. Yeah, these kind of systems usually provide a kind of skeleton for what people often see. So, you know, within a software solution, there will be a lot of additional information that's collected about people. For example, in a system like ACIITC, some sort of record of whether the person has a hearing problem and how severe it is. But if the person does have a hearing problem, there may be a series of other data that's collected. Do they have a hearing aid? Is it kept in the top drawer of their cabinet or in a cupboard? You know, this kind of stuff that is very important, but it only relates to a subset of people that have got a hearing problem. So you can see how these systems that Ronald's been talking about are basically core to the sort of broader software solutions that people use. But of course, many of the current systems don't have a core. They simply just a whole lot of assessment data items without really a proper structure. So that's what differentiates these systems, really.
Yeah, I think that's an important point because, like you said, we do capture a lot of data in clinical systems, but they're not captured in a structured way that we can use for assessments. Going all the way back to initial assessments like ACAT and RAT assessments, do you see a role for these CGAs at that level of assessment as well?
What we think it should happen is to have data flowing between those different assessments. So it would be nice if those ACIITC and initial assessments are conducted using the same assessment tools, so that the data that is collected at initial assessments can then filter through to the updates on assessments, as well as future assessments, so that we don't collect, because some of these data items will be quite static, things like disease diagnosis. Those, if somebody has diabetes and it's diagnosed, it's listed as present in the initial assessment, you don't need to be collecting that over and over again. So use the same system. Data flows through from initial assessment through to the regular updates of assessment that happen, whether it's every quarter, every month, or whatever frequency that is adopted by the providers.
Excellent. Thank you. We do have a question here, and you may be able to highlight it. Were software vendors invited to provide information, or was the assessment done based on information available? Now, to your earlier comment, the standards-based system is not necessarily a software system. It's a system that can be integrated into software. Is that correct? So that's not.
So yeah, let me just make sure I'm understanding that question correctly.
I think the question is along the lines of the software vendors who provide the solution, were they evaluated, or are you looking at the system itself within how it? Yeah. So
what we only looked at was the actual systems, not the suppliers of the software that will be used to implement those systems. Okay. So I think I might have mentioned that Inter-Eye systems, for example, they do have a wide range of vendors that are accredited by the organization to provide solutions for Inter-Eye systems. Now, there are so many. That would be a project on its own. So we didn't go into evaluation of individual software suppliers.
So I think what the takeaway message there is that the standards-based assessment tool can be integrated into existing and new systems, and that's part of the discussion we're having here about which tool to select to integrate, so that you have a standardized format going forward.
That's precisely right.
Fantastic. Look, I think we're sure there's lots of more discussion that can be had. But the questions around data definitions and classifications are important for consistency. What do we do to ensure that the Australian definitions that we use locally can be integrated into these assessment systems? Any comments around country-specific applications versus generic international applications?
Yes, absolutely. So what normally happens is whenever a country intends to adopt one of these systems, they have to conduct tests on top of what's already been done in the development of the system to make sure that it is valid and reliable for use within that specific population. And as part of that process, that may include things like translations into the local languages, as well as making sure that definitions for data items are in line with what is used currently in those countries.
Excellent. We have a question here. Sorry, go ahead.
Yeah, I mean, data in these systems kind of consists of identifying information like gender and such things, and they have to be, these systems need to be adjusted to the local definitions of those things. Then you've got transactional information like date of admission and all that kind of thing. Again, they're often it's a standard in each jurisdiction that dictates what's done there. What's much more solid and standard is the clinical information. For example, the diagnosis of diabetes, there's a universal kind of approach to that. It doesn't need to be adjusted for each jurisdiction, and similarly ADL function and so forth. They are pretty much stable across all environments in terms of the way they work. So you do need some local customization, but mostly around the identifiers and the transactional information.
I guess that ultimately people age pretty much universally around the world. It's not we aren't unique in Australia in the way we age. Very quick question, because we are running very short on time. We've got a question here that many service providers deliver services to aged care and disability sectors. Can these CGA systems support disability assessments?
Now, these are strictly for comprehensive geriatric assessments.
Okay.
There are some systems that are tailored for an adult population in general. So we did not consider those in this review, but there really are some that are for adults.
I can speak on behalf of Indira because I belong to the organisation, but the Indira has systems for intellectual disability and also for persons with disability. It also has paediatric and mental health systems, all of which share much of the same data set. So there's a whole suite of systems that use the same data items to characterize individuals' problems. So there are solutions, and in a wonderful world, we have the same descriptors across the
Fantastic.
whole. Yeah.
So noting we are on the hour, first of all, I'd like to thank Ronald and Len and the team at UQ for some amazing work. I think the report's been fantastic. We are getting a lot of questions about what are the next steps. I do highlight that keep an eye. We will keep being in contact with you about next steps. As we discussed earlier, this standards goes beyond just assessment. It goes across the whole gamut of requirements around age and community care. So at the council, we're very keen to drive that an evidence-based, standards-based approach going forward. So we will be in touch. Our contact details online. Recordings will be made available. Feel free to share this recording with your colleagues. Feel free to be in touch with us. And like I said, feel free to use the ACIITC Council's LinkedIn group for ongoing discussions. I suspect, and I'm sure Len and Ronald will agree with me, we have a scope for a number of other webinars going forward to run these discussions. And with a bit of luck with 2024 around the corner, we are looking to relaunch ITAC in 2024 after a 1-year hiatus, so we can actually have some much more exciting discussions in person. So thank you very much for our speakers. Thank you for all of you for attending and joining us today. I hope you found this very informative. The discussions on the questions suggest there's a lot of things that we need to work on, and we look forward on working with you all together to solve those issues as we move forward for better digital aged care in Australia. Thank you very much.